Hi, it's Michelle again, and we are going to continue with this series of e-lectures on cognitive and perceptual interventions, and this is part 2. So we're going to focus now on cognition particularly, and in terms of cognition, we look at a couple of aspects or a couple of cognitive functions. These cognitive functions are arranged in a hierarchy. So from the bottom moving up, to be able to function cognitively, the first thing we need to do is to pay attention. Once we've paid attention, we then need to be orientated to where we are and who we are and what we're doing. Once we're orientated, we then need to engage memory and understand what is happening and remembering what's happened in the past and compare that to what we know already. Then only can we get involved in executive functioning, which is one of the higher cognitive functions and something we see a lot of in our patients and a lot that we work with as occupational therapists. And finally, at the top, we have mental flexibility. So I'm going to go into these in a little more detail in the following slides. The first and most basic of all the cognitive functions is attention, the ability to pay attention. It's even acknowledged in the Ranchos Los Amigos scale, where the first thing you look at in the recovery from coma is, can people actually pay attention? Are they aware of what's going on around themselves? In some clinical fields where this is really important, we actually alternate, we actually will differentiate between different types of attention. So is there ability to have focused attention? That's actually pay attention, being aware that something's going on in the room. Can you have sustained attention, that actually you can concentrate on something for a long period of time or maintain your attention on something? Have you got selective attention, in that you can actually stay focused and not be distracted by other things? Do you have alternating attention, where you can actually pay attention to more than one aspect? Or divided attention, you can actually do two tasks at the same time, like maybe cooking dinner at the same time as having a chat with someone else. Please avoid the term concentration, because I think we tend to, as everyday citizens, talk about concentration as being the same as attention, but this gets a bit confusing. So please refer to the term as attention. And if you're looking at this from a clinical perspective, we look at, can someone sustain the attention? Can we improve their attention? If someone can't pay attention, it's really hard to move into the next cognitive functions. It's a precursor to all other cognition, obviously. And sometimes to treat attention, what do? To try and get people to actually pay attention, to engage, to respond to us, we try and engage in pre-morbid interests. That might be something like bringing music that they recognize, photographs of people that have been in their life before. It's quite common in a rehab setting to have photographs of sports stars to try and encourage some kind of response, or to have music on your phone that they might recognize. And that's really involves speaking to the people's family, your client's family, and finding out what they were really interested in before. Sometimes it involves use of reward, and it's going back to sort of real basic concepts, almost the same way you would with a child. Increasing arousal is sometimes possible through physical activity, and in a clinical setting, there's often a remedial task to try and actually improve someone's attention. So there's actually structured activities to improve attention, and we will talk more about interventions as we go along. Next up, we talk about orientation. And I think orientation is something we understand fairly well when we think of an elder population, but in this course, we're focusing on adults with acquired neurological conditions perhaps, or maybe an early dementia. Orientation is really about, can you orientate yourself to place, time, and orientate yourself to actually know who you are and who everyone else is. People can become quite disorientated. In a clinical setting, you might see disorientation in people with delirium. And what I mean by delirium, I think we can remember OCC311 from last year. Delirium is a transient state where people are a little confused because of chemical imbalances or dehydration. In delirium, they might not know that they're in hospital. They might be a little delusional. With people with dementia or with more severe cognitive issues, they might not know the place they're at for a prolonged period of time. They might not know what time of the day it is or what date it is. They might think it's the wrong year. They might think it's the wrong season. And they can be quite disorientated. They might have repetitive questionings, asking you, where are they? What are they doing? How do we intervene? What do we do? Really, it's a lot of prompting. And this is great. So if someone is recovering or getting better, you might decrease the amount of prompting, but if they're not, you might increase the amount of prompting. You provide as many cues for your orientation as possible. Like, for example, in this photograph here, you have charts that tell you what time of the day it is, what the weather's like, who's on duty for the day if they're in a care facility. We put a label on items, so sometimes people might forget that something's a toothbrush, and it sometimes actually needs a label of a toothbrush. So there might be an excessive level of labeling, and that's really compensation, isn't it? It's trying to compensate for the deficit and teach people some sort of strategies. And we're going to get into that in the rest of these slides. Now, third is memory. Now, you've covered memory extensively in OCC311 with Anita, and looked at different types of memory and understanding how to assess memory. Now, from this perspective, we're looking at how do we treat memory, or how do we incorporate or be aware of memory when it comes to adult interventions. So we know that memory is a process of storing information, retrieving information, and then doing something with that. And it involves, surprise, surprise, number one, attention, encoding, then storage, some consolidation and retrieval. And I think if you remember from your 212 lectures, there's some quite complicated theories about how we do this. And so sometimes we have to pull on learning theory as occupational therapists to try and help people improve their memory. It is again reliant on attention, but it's also reliant sometimes on perception of what's around us. And sometimes there's an element of orientation as well. We need to be orientated to where something is being presented to us. Obviously, there's two types: short-term memory, which is quick recall, or long-term memory. And we know people who have significant new memory issues, they might have intact long-term memory but no short-term memory. There's also the explicit versus the implicit. Explicit being the facts and events, where the implicit is more the procedural and the emotional memory, and they might be different. We also need to look at types of interventions. So from a memory perspective, what do? We do things like memory drills to try and improve things. We use strategies. We might use computer-aided apps. We might just compensate with a memory aid. So we need to determine for each of our clients, is this something that can improve so we can try and give them ways to get better at their memory, or is it something that we have to acknowledge as a real issue and therefore we need to compensate and continue with memory aids or things like that. Now, executive functioning or executive functions. This is going to be quite a long slide. I'm going to talk quite extensively here because this is one of the most important areas for occupational therapists. We do a lot in executive functioning with people with traumatic brain injury, with stroke, multiple sclerosis. There's an overlap into the older population because this is the real thinking stuff. So this is the real cognition. So this is the bit where we as OTs are helping people to manage their own cognitive actions better. And there are things that can go wrong, or there are things we can target. So they're serious cognitive skills. So some of these are initiation. That's the ability to start something new. Sounds strange that someone might not be able to start something, but after a traumatic brain injury, or maybe having had been in a coma, people who are that unwell and are recovering their cognitive functions really won't be able to start a new task, won't be able to initiate something. And this means that as therapists, we have to find a way to cue them to start, and then find a way that they can actually try and cue themselves and to try and get starting. That means we might need to use verbal cues. You might be reward them. Sometimes it's just creating a stimulating environment that means that they are cued to want to be involved or engage and to do something. And again, as I mentioned with attention, we might look towards their pre-morbid interest to try and make this more engaging for them and more personal and more specific to the individual. Self-awareness is a biggie. And I'm going to take a while to talk about this because self-awareness is, for me as a clinician, absolutely crucial to recovery, to the implementation of strategies, the implementation of any kind of improvement. Because if someone is not self-aware, or as we often say in clinical settings, if they lack insight, they can't regulate their own performance. They don't know that there's anything wrong with them. So they may overestimate their abilities and underestimate their disabilities. And family members are really keen and quick to hop on and say, yes, they're actually doing really well, when sometimes they've got some severe issues, especially when it comes to executive functioning. Because someone might have recovered really well and shown such progress from being in a coma, but to actually being able to think and to do the higher level executive functioning, that might not be possible. And they may then have a lack of self-awareness about their abilities. So as a therapist, we can do a lot of things, and this has been discussed in the textbook, but it's really about using feedback, use of things like video, sometimes even staging failure so that they can see what they're getting wrong. So someone really needs to be aware that they aren't successful, to become aware of their deficits so they can then work on getting better or compensating for that deficit or challenging that deficit. So it's a really important part of therapy, and I can't stress it highly enough. I think from a clinical in a clinical setting, I spend a lot of time trying to work on someone's self-awareness, because the rest isn't important if they're not actually engaged. One that comes to the top of mind, you say executive functioning, everyone thinks planning and organization. So can we actually organize what we're doing every single day? Can we set our own goals? And these can be targeted in the therapy setting by using tabletop activities, by doing things like community outings. So it can either be something contrived and in a therapy setting, such as a tabletop activity, or it can be actually going out to the real environment, so into someone's own house, community, maybe doing some shopping, maybe doing some cooking. And we're going to do some of these things in the in-class activities. You guys are going to plan some of your own therapeutic interventions to help someone with their planning and their organizational skills, as well as problem solving. So sometimes it's hard to differentiate planning and organization and problem solving. The problem solving is really the what to do when something doesn't go wrong, doesn't go right. So it's about, in a real task, there's too much water in the cup of tea, or there isn't enough tea, or not really sure how to go in the next step. So it's that real unplanned scenario where someone has to know what to do or has to try and work out what to do. So that means we normally use functional tasks, might do the graded assistance, and there might be a bit of prompting as well. This is a cartoon for your own perusal. Move on to the next one to just break things up. And finally, the top is mental flexibility. Now, mental flexibility is, for me, is something I hadn't come across clinically. It's come straight out of the textbook, because I think as a therapist in a rehab setting, generally you don't get to the level of mental flexibility. Most of our clients that are coming to us needing OT actually have executive functions primarily. So getting to mental flexibility is that ability to abstract, to think conceptually, to envisage plans, to envisage the future. It's compared with concrete or literal ideas. So it's a tricky one to do as a therapist, and it's going to be your clients with a much, much higher level of function. Almost the people that don't seem like they need OT might need some mental flexibility work. This might involve doing visual and auditory processing tasks with lots of information coming through, so someone really has to think and process what's going on. And normally when it comes to something like mental flexibility, I would work alongside of a neuropsychologist, possibly a speech therapist, depending on the person's actual pathology and how they're getting on. Okay, now that you've got an idea of what a few of the perceptual and cognitive functional concepts are, can you move on to part 3, where we'll actually talk a little bit more about interventions. We've already covered some of this concept, but we can try and pull it together in the next set of slides. Thanks very much.